It just keeps marching on. All right. There's somebody on my Facebook is counting down the days of like COVID, and I think it was like day 150 something, and I'm like, oh my goodness. Okay. No. It's going to turn into a year here pretty soon. Okay, so we're talking about engaging patients at various stages of change. This is our global learning objectives. And today we're talking basically about harm versus abstinence-based philosophies of care, and just talking about, depending on the stage of change the person's at, you might want to do different engagement strategies. So I don't think there's anybody on here this morning that doesn't know me, but my name is Delos Reyes, and I am an addiction psychiatrist working at University Hospitals in Cleveland. So I like to start out here, which is with things that patients say sometimes, and how we sometimes want to react to that. So certainly depending on where the patient is at, we're going to have different interventions. So some patients come to you and they're forced to be there by criminal justice and saying, okay, I'm only here, you know, I don't really want to stop using. Some people come and say, well, you know, I'm not really an alcoholic, take it or leave it, or I don't want buprenorphine, that's a crutch. People, you know, you get a few that actually are like, yes, they help use anymore. And again, remember that the stages of change is not, it's not it is specific to a particular behavior. And so one of the things that's important is to figure out what's the target behavior that you're talking about. So for instance, somebody might be interested in some of what you have to offer. So they might want to take medication, but maybe they don't want to go to meetings, or vice versa. They'll go to meetings, but don't want to do with your medication. So again, it can vary from behavior to behavior. And so if you're familiar with stages of change, you know, Prochaska, DiClemente, and motivational interviewing, then you'll know that your intervention has to switch up based on where the patient is coming from at that particular time. So there are some key questions that I have borrowed both from motivational interviewing and from other ways to interact with patients. And when I feel stuck, these are some of the questions that I turn to. For example, I try to find out what matters most to the person, what are the goals, how important is it for them to quit using at that point in their life, and then I also confidence, you know, do they think they actually could do it if they tried? And if they are coming at me with a lot of unwillingness to do this or to do that, I may sort of say, okay, you've told me what you're not willing to do. What are you willing to do at this time? So that's a way that I can try to get to a place of partnership and a place of meeting the person in the middle and trying to figure something out. So again, there are going to be times when you can't use these and you just have to put your foot down and say, I either feel safe or not safe doing this, or this is clinically not indicated, or this is clinically indicated. You know, so that does happen as well. But quickly, these are some things, some questions that can help you feel or get unstuck with your patient. Harm reduction and abstinence only. I put the terms in quotation marks because they're not the perfect terms. I do believe it is a continuum, and there's a lot of shades of gray in between, but this is something I would define or call the philosophy of care. And so your program and you as an individual might have a particular philosophy of care, and it comes from your background and how you were trained and what you believe. So these are very kind of personal things, and the philosophy of care that you carry will actually have implications for how you treat patients. So it is important. And if you're working in a program where the philosophy of care is very different from your own, you might feel like a disconnect. And so it's important to find a team of people and to find an agency which has at least a similar enough philosophy of care to yours, so that you can feel some and sort of a sense of, hey, everybody's on the same page here. Because I've definitely been in programs where that's not the case, and it can get pretty uncomfortable. And I've also seen it where the philosophies of care were so different that people just decided to leave the agency. So I've seen that as well. So it's pretty fundamental stuff. I don't think, you know, sometimes I think of these two things as being far apart. And then sometimes I think of them as being close enough together, except with just some really distinct ways of looking at the world, kind of like Democrats and Republicans. No, sorry, I really won't go there. It's way too early for that. Just kidding. So let's just focus on the disease of addiction, right? That could be a really interesting conversation. But on the harm reduction side, which is on the left, um, you know, certainly I think most people that have this philosophy do feel that addiction is a brain disease. And I have met people with an abstinence only philosophy that feel that addiction is a brain disease. But the subtlety is that, you know, brain disease that can only improve with abstinence. In other words, abstinence is the be all way of treating that particular brain disease. So certainly we can agree on brain disease, we might disagree on how to get somebody into recovery. Okay. So and certainly in the abstinence only side, there are those that believe that no, addiction really isn't the disease, it's really just willful bad behavior on the patient's part. And if the patient really wanted to change, then they would, that they can decide that they're going over for the rest of their life. Interesting. I mean, I think we can certainly talk about that. I mean, as a pharmacist, I do feel that there is some decision making that has to be done, but I also sort of see that as interplaying with the brain disease. So I think it can get to be pretty interesting. For me, a person that has addiction certainly has an illness or a sickness. I do believe that most of them are trying to get well over time, and I look at abstinence as a goal, but long-term goal. It's not a goal that I expect them to come up with tomorrow. Whereas I think with abstinence only, in a philosophy of, well, look, you've got to quit today and stay quit, and that's what you do, and anything else will fall short. So you get that sort of feeling. The other thing that happens is that when a person doesn't follow the treatment plan, that gets talked about in different ways depending on the philosophy of care. So if you're in a harm reduction philosophy of care or that type of program, you may actually hear that the language is different. So you might hear people talking about unexpected urine drug screen results versus urines, right? And so I have definitely worked in programs, and this is going back 15, 20 years, but I've definitely worked in programs where you actually would get charged for using drugs or alcohol, even though you were in a treatment place where you were trying to get help for using drugs and alcohol. And that never made a lot of sense to me, but the counselors would basically say, well, this person must not really be serious about getting well, and they're going to come back when they really are serious. So definitely the way I practice now is very different than the way I learned it from the old drug and alcohol counselors that I worked with. And so first, following the treatment plan, and they seem to be doing everything to sort of sabotage the plan instead of maybe pointing fingers at the patient or sort of participating in what I sometimes see as victim blaming. I might say, well, okay, what is it about our program that isn't meeting the needs of this particular patient? What can we do to increase the support for that patient? Whereas that same exact behavior, right, as well, this person's broken the rules, we're going to call their probation officer, we're going to have to kick them out, and we will sort of, quote, teach them a lesson, and then maybe next time we won't bring as much. So again, very, very different attitude when it comes to that. So yeah, that's a little taste of how the two might be different. And it's all about point of view and perspective. Again, if you're a farmer and you look at this picture, you say, wow, that's some nice dirt and it's got some potential. And if you're not a farmer and, you know, you might just say, oh yeah, that's just dirt, right? And so you have a very different philosophy based on where you come from. And so again, I sort of like this slide because it reminds me that my patients that sometimes get treated like dirt and feel like dirt, and I try to be the farmer and say, well, hey, this person's got potential and this person can get recovery, and it's my job to sort of guide them there. I can't do it for them, certainly, but I can try to make the way a little bit easier. So for those of you who've seen this before, which I think is almost everybody, this is the point at which I usually ask for a volunteer. So I will do the same thing again today, which is if I can get a volunteer to read. I have 2 case examples, so I'll actually need 2 volunteers, one person that's willing to read case example number 1, and a person to read case example number 2. So, so yeah, somebody that's.
I'll do it for once.
All right, Will, thank you.
I'll do it in my narrator voice.
Oh, good.
DM is a 30-year-old sugar addict. He was arrested yesterday for sugar possession with an intent to traffic. He brought donuts to his job. He had 4 previous dirty blood tests with hemoglobin A1C greater than 10. If he has one more dirty blood test, he will be discharged from the clinic because he will only treat sugar addicts who can keep their hemoglobin A1C below 7. He will be sentenced to 90 days of intensive nutrition class and have 4 random blood glucose checks weekly. He also needs to attend 3 Donuts Anonymous meetings per week to get his sheet signed. If he overdoses on sugar again, he goes into DKA. He will get charged with sugar possession. After he gets out of the ICU, he will go straight to jail for a 30-day stay. That will teach him to never eat sugar again.
Thank you kindly, sir. And then I need a reader for case. There's got to be somebody out there. Who's doing it?
Dr. Chris, I can do it. This is Kelly.
Thank you. Oh, thank you, Kelly.
You're welcome. Sud is a 40-year-old woman with opioid use disorder. She overdosed last night on heroin. She was admitted to the ICU and treated with grace and dignity until she fully recovered. She was not discharged until she met a peer support worker and a counselor and saw psych for depression and PTSD. Her buprenorphine prescription was filled, the prior authorization was done, and the nurse taught her family how to use a naloxone kit in case of another OD. She had a follow-up appointment with an addiction medicine specialist within 3 days of discharge. A visiting nurse checked on her daily for 1 week to assess her recovery status, medication compliance, and ensure rides to 12-step meetings in IOP. Her family was kept informed of the ongoing treatment plan and given information on family support groups.
Thank you. So my question to the audience is, what's wrong with this picture? What do you think about case example number 2? Are there any parallels that you see? Parallels that you see in your own practice as you practice today? I am just looking for sort of your feedback on this, both sort of from an education standpoint as well as from an emotional standpoint, I suppose.
I mean, I was laughing, just you guys, Dr. Block is on a call this morning, which I'm so excited to have him on. I was laughing because we use this example of diabetes all the time. We are a very harm reduction program. And it was just very, I mean, we would never say something like that. We would never, ever talk about someone like that who has diabetes ever. We would never, like, it's malpractice to not give someone who has diabetes insulin to control their illness. And it's giving me chills, and I'm very passionate about it, obviously, just even talking about it. So I just appreciate this presentation more than you know. Yeah. So it's I think a little bit of coping for me to just hear that out loud as it was written, to laugh at it, because man, it is so prominent, not just probably where we are, but just everywhere. It's just, addiction's just thought of differently.
Yeah, thank you for that. You know, I think I must have written this, I don't know, 4 years ago now or something like that, or 3 years ago, and I read it today, and I'm sad because things still haven't changed, and my patients still don't get treated like the patient in case number 2, and so I guess that's why I still keep coming to work, because until everybody gets treated that way, you know, then I don't feel like I've done my job properly.
No, Chris, I was thinking, when I hear that, well, first of all, I completely agree with what Kelly said. Then thinking about Dr. Ballister's presentation last afternoon, it's just, it's to me, you know, where it basically, so one point was that there's pretty good research in Australia, in Canada, I believe, and England, which suggests that offering people a place to inject their drugs can reduce overdose and also make them more likely to engage in other healthcare services, right? So some of the outcomes we'd be most concerned about, which is overdose rates and people being linked to healthcare services, seems to be enhanced by, you know, that type of programming. But like as a culture, and even me personally, like I struggle with, God, am I okay with that? But to me, that struggle with am I okay with that has nothing to do with the science and the outcomes. It has to do with this belief about substance use, which is, you know, and I'm a person in recovery, so it's even uncomfortable for me to say that, but it's, you know, it's something pretty deep, I think, culturally in the United States, certainly around beliefs about people with substance use disorder. And there is a little bit of a disconnect, even for me, like, is it really a medical issue? And do we really just need to look at the outcomes?
Right.
Or does there need to be this kind of harshness to the treatment? You know what I mean?
Oh, I know exactly what you mean. And again, the thing that still echoes with me, echo, pun intended, I suppose, echo last week was that even in a secret, undisclosed, clean shooting place in the United States, we already have the data for the last 5 years that shows that it actually works. And in the face of data, what are we supposed to do? And most of us that come from a healthcare scientific background, you know, the data is supposed to perhaps change the way you practice. And so, but changing the way you practice, it's complicated. It's not just, oh, well, I see this data and I'm going to change the way I practice. You practice in a system, and if that system is not supportive, you're not going to be able to practice the way you want to practice. And so then it gets into advocacy and changing the system. So that's, you know, so that's the kind of stuff, like I said, like I like to say, that keeps me up at night. So when I'm supposed to be sleeping. So anyway, but yes, thank you for that feedback. Okay, and again, and I think one of the most important things is naming, right? So we as human beings, we like to name and label everything. And we've known for what, years or really forever, that words are important. And if you want to take care of something, you'll call it a flower. And if you want to kill something, you call it a weed. And many of us, I can remember myself being a person bringing a dandelion to my mom and saying, Mom, I've got this pretty flower for you. And my mom would just laugh. And then the same thing, my kids were 5 and they would bring me a dandelion, and something happens to a person between 5 and when they become a parent. So as a parent, I was like, oh, you know, you want to say, oh, hey, thank you, which of course I did say, but in the back of my mind, I'm like, well, that's a weed, you know, like that's a dandelion, and I got to call the, you know, my lawn guy and make sure that he puts extra, you know, weed killer on my grass, right? So it's like, what happens where somehow a dandelion goes from being something beautiful when we're 5 to being like something we want to kill because it makes our yard look bad, right? So there is something about that shift. And again, we can shift back. One of the things I also clearly remember is when I first started working with people that worked in criminal justice, and I would use the word patient, I would get corrected, and they would say, no, not patient, inmate. And I was sort of taken because I was like, oh, inmate. Like, so when you're a corrections officer, everybody around you is labeled as sort of like an inmate, which is one of the bad guys. And again, I can remember being corrected, and they used language very differently than I used language. Like, I saw those people as people and patients, and they are socialized to see people as inmates, because I think they're not able to do their job unless they're able to label people that way, right? Because I think, I mean, again, I've never been a corrections officer, but I can try and put myself in the place of a corrections officer and go, wow, that would be really hard. Really, what separates, you know, what separates you from them? You know, you have the keys. I mean, that's kind of how I feel when I'm on an inpatient psych unit, right? Like, how can you tell between the patients? Well, the staff are the ones that have keys, but really, are we all the same, right? So the only difference between, right, the corrections officer and the inmate is that the corrections officer has the keys. So it's, again, it's this really interesting thing that I think we humans, and we have to do it with like labeling. And again, I think that's hugely important with things like racism and all that stuff that's going on today. I mean, you can't look at the news and not think about it, I guess is the way I would look at it. And so this presentation for me is sort of hitting home a little bit more, because I do think a lot about other people and how we put people into categories, and then that allows us to make differently. Because if you're an inmate instead of a patient, I might have a different attitude. So Ohio has taken a step recently. There's the Ohio Language First team, and they've printed up things about supposed to be for anti-stigma that we can have in our offices, or put up on our walls. So this is an example of like card, a little skinny card that you can put in your office. And then this is sort of a bigger brochure, and it just talks about addiction disease and how we ought to think about it that way, and that language matters, and that very similar to, we shortcut things in medicine and we'll say, oh, diabetic, or, maybe we should say person with diabetes. So instead of saying addict, maybe we should say person with a substance use disorder. So those little tiny changes, I think that's what's going to help in the long run. So I like to end by this story from Tara Brock. And again, this is that when we are treating patients, we often see patients at their worst. And this helps me to remember that, maybe there's a chance for them that they can show me different behavior in the future. So I'll read you the story. Imagine you're walking in the woods and you see a small dog sitting by a tree. As you approach it, it suddenly lunges at you, teeth bared. You are frightened and angry, but then you notice that one of its legs is caught in a trap. Immediately, your mood shifts from anger to concern. You see that dog is coming from a place of vulnerability and pain. This applies to all of us. When we behave in hurtful ways, it is because we are caught in some kind of trap. The more we look through the eyes of wisdom at ourselves and one another, the more we cultivate a compassionate heart. Now, clearly, I'm not saying that you should let your patients abuse you and treat you like crap. You do have to set your limits. But when you are having one of those days where it seems like everybody's yelling at you, especially from the patient side, I often think of this little story and go, man, they've got to be coming from a place of a heck of a lot of pain, which is, and it's coming out in their behavior toward me. So it helps me to perhaps not take it so personally. But yeah, it doesn't feel yelled at. So yeah, that's for sure too, which is why we are able to have a place like this where we can talk about it. So yeah. And every once in a while, and there's my little dog, the other thing that makes me happy, Layla.